timely topic. He's going to give us an update on male hypogonadism. Most of you probably know Rami, but he has multiple certifications in endocrinology and related disciplines, and he's an excellent speaker on these topics, so we're pleased that he could be here. Make sure you sign in at the front if you haven't, and please fill out your evaluation forms when you leave the program today. Rami?
Thanks, Jamie, for the introduction. Thank you, everyone, for coming this afternoon. I'll be talking about a topic that's probably hot and gained a lot of publicity in the media. I think probably a refresher on male hypogonadism is important, just to know how to diagnose it, how to treat it, and to probably talk a little bit about the new studies that raised the concern about the cardiovascular safety with that. I'll be starting with a small video clip there about the report on hypogonadism, and then I'll have my slides after that. I'll have some questions at the beginning of each part of the slides, and there will be multiple choice questions. I would like you to help me answering these questions. So I'd like you to use the audience response system there. I'll encourage you to use that because the person who will be answering the most questions right will be winning a nice prize, which is a testosterone gel for a full year. So without further ado, I'll start.
We take a look into a kind of secret society, baby boomers ready to do whatever it takes to stay young. Since 2006, prescriptions of testosterone have doubled since 2006, and they're expected to triple again in the next 5 years. ABC's Neil Karlinski tells us who is doing this and at what risk.
They are a mountain of aging boomers.
Got my mojo back.
I think every guy over 50 should be doing it.
Putting their younger, ambitious coworkers on notice. They plan to keep winning in the boardroom, in the bedroom, everywhere.
I mean, honestly, I like looking at myself in the mirror because I look frickin' awesome.
He says the secret is testosterone, which 57-year-old CEO Chris Running showed us as if it was no different than a glass of orange juice.
So that's it, twice a week?
Yeah, you know, our generation is trying to stay as young as we can for as long as we can.
You can see it in those ads, appealing to the 70 million boomer men unwilling to fade quietly into old age.
You might have a treatable condition called low testosterone or low T.
A boost of testosterone, long the illegal drug of choice in sports, is being touted by some as a virtual fountain of youth and just a prescription away.
I've gone from a 38 waist, relaxed fit jean to a 34 slim fit jean, which I never in a million years thought I could get my one leg in one of them.
In the 3 years he's been taking T, Chris says he has transformed himself into a younger man. 2 hours more work per day, 30 pounds of fat gone, and muscles, bulging muscles, more impressive than anything he had in his 20s.
Do you notice the physical change too? I mean, he talks about 30 pounds.
Yes,
muscle.
absolutely. And he looks great. He's in great shape.
We wondered, can it really be that simple? Dr. Karin Power says yes.
I hear a lot of men come in and they talk about the young guys coming in that they feel the challenge.
Is that okay or is that cheating?
If your levels are low and I bring you back to a normal level or an optimal level, then aren't I just, leveling the playing field?
So what is normal for what age? The average 20-year-old's testosterone levels can reach as high as 1,080. But as you age, the levels drop without drugs. By age 60, the average high is only 720. So is it right to pump up testosterone to the levels of a much younger man, a level that in many cases more than doubles a man's testosterone? Not so fast, says Dr. Edmund Sabani, an expert in testosterone at the prestigious Cleveland Clinic. He's worried about the wave of boomer men using T to stay artificially young.
Right now, we don't have guidance in the medical research that suggests it's safe to stay at those levels.
And there are serious possible side effects of too much testosterone: blood clots, liver damage, and some doctors are concerned about its impact on prostate cancer. The New England Journal of Medicine warns that only about 2% of men over 40 should be getting any boost at all. Chris Running and the growing number of boomers just like him aren't worried.
The bottom line, I mean, you're sold.
I'm absolutely sold. I will never not do this.
Risky or not, he says slowing down so the next generation can move up is not an option. Neil Karlinski, ABC News, San Luis Obispo, California.
So I think that video will give you an idea how the false advertisement works. So they didn't mention anything about how much exercising he's doing, how much his diet has improved. They said that his testosterone was low, he took the shots, and he's a different guy. And I think that's what every person who's watching this commercial will get this idea. So it's very common to have like false advertisement, and that will lead to more testing, and I think looking for more testosterone problems. Hopefully at the end of this talk you'll understand how common is this problem, how is testosterone produced in normal physiology, and what the presentation, what to expect symptoms and signs to look at when you're looking for hypogonadism in men. Know a little bit about the causes of hypogonadism, how to diagnose it, how to treat it, and how safe is the treatment is. So I'll start with a little bit about the epidemiology, and I would like to start with a question here. All right. So what do you think, what's the prevalence of hypogonadism in men older than 45 who are going to the primary care office just for a visit for other reasons? 7%, 15%, 23%, 30%, or 38%? I think we have 26 people, so that should be good. So the answer is actually 38%. And I will tell you, this is actually a very famous study. It's the Mulligan study that was published in 2006. What they tried to do is actually to try to get the first 2,100 patients going to their primary care office, just took blood samples from them. And they defined hypogonadism in that study as lower than 300 nanogram per deciliter, which is a little bit, I think I would say, liberal in diagnosing hypogonadism. But they found that actually 38.7% of men older than 45 who went to their primary care just to visit for other reasons, they found to have a low testosterone level. So it's very common. And if you try to translate that to numbers, how many million people in the United States have this problem, it would be probably in the 10, 12 million percentage or number. And I think it's a little bit overestimate of what the real problem is, but at least it's an eye-opener how common is that problem. And of course, they found that obesity, diabetes, and hypertension will be the highest risk for having a lower testosterone level. The other, probably another reasonable study, which was the mass male aging study, in which they tried to estimate the prevalence rate of androgen deficiency, and it was about 12%. The difference between that and the Mulligan study is probably the criteria for hypogonadism was 200 in this study, so that's 12%. So I think in general it's common. And just to put you in perspective, how common is that is when you try to diagnose thyroid disease in general, it's about 5 to 10% of the population have thyroid problems, and that's very common. So it's actually more common than thyroid problems. So it's reasonable to screen for it. Other part of epidemiology I would like to touch on, and probably we'll talk more in details at the end about the cardiovascular safety, is one interesting study, which is the EPIC Norfolk study that they studied about 1,100 men over a period of 10 years. It was a case control study. And they measured the testosterone level, not necessarily their own replacement, just the endogenous testosterone without any replacement. And they found that there's an inverse relationship between the testosterone level itself and cardiovascular mortality, all-cause mortality, and even cancer. So raising the question about, is low testosterone a marker for bad health, or is it a cause of bad health? And that's probably is not the focus of this study, but it's something to raise the question, and I think that's where all the confusion happens. Is it people with low testosterone have low testosterone because they're sicker, they have other health issues, or the low testosterone is causing these health issues and making them sicker? So you can see the previous slide was the total mortality in comparison to time over time and different quartile of testosterone levels. So the highest testosterone levels, endogenous testosterone levels, actually have lower mortality in comparison to the lower quartile. This is cardiovascular mortality. People dying from heart disease was higher in people with lower testosterone level as a baseline. So hopefully by now you're convinced this is common and it's associated with problems. And I think one point I would like to emphasize here, that if you identify a person with really low testosterone, one big thing that you need to remember, it's a marker there of actually a bad health. So if they're diabetic, they need to improve their diabetes. If they have high blood pressure, that needs to be addressed. If they have dyslipidemia, that needs to be addressed, because they're at very high risk for actually getting into trouble from cardiovascular disease because of that marker there. I'll talk a little bit about physiology, and the reason why I want to include physiology here is because most of the diagnoses that we do and the labs that we do, we have to understand the underlying physiology behind it to make the right test and to order the right test for that. And to test you before we talk about it, let's ask you this question. What do you think, what time of the day testosterone level will peak in men? Like in the morning, early morning, mid-morning, afternoon, evening, or midnight? All right. So the right answer is early morning, and 70% got that right. And the reason why it's early morning, let's see. There we go. So this is one of my favorite graphs, which is graphing the normal testosterone levels during the day in healthy young men. So on the y-axis here, you'll see the testosterone level. X-axis is actually during the day. So you can see that testosterone level actually starts on the low side to start with at night, and then it builds up overnight, and then peaks. Oops. It peaks at probably 8 o'clock in the morning. That's when most people wake up, or 7 o'clock, and then goes about 50% lower in the afternoon and even lower at the end of the day. So the best time to check for a testosterone level would be after waking up from sleep, and typically fasting before they eat, because some studies show that food will reduce testosterone level by about 20% or so. So it's better to do it fasting. This is a simplistic cartoon about how testosterone is produced in the body, and we know that the hypothalamus will be producing what we call gonadotropin releasing hormone, and that's produced in pulsatile matter that will go to the anterior pituitary gland that will make the pituitary produce luteinizing hormone and follicular stimulating hormone, the LH and FSH, and that in part will start to make the testes produce testosterone, inhibin, and induce spermatogenesis. And testosterone, on the other hand, will go and have a negative feedback on the pituitary gland and to the hypothalamus, and will be an equilibrium there between all of them. Another important fact or information I would like you to know about is what's the difference between the total testosterone and free testosterone, just because that might be an issue also when we check the testosterone levels in men. So usually the testosterone is bound to either sex hormone binding globulin or albumin in about 97%. So there's only 3% of the testosterone is free and floating, and actually that's the one which exerts its function there. The others is bound loosely to albumin and some to the sex hormone binding globulin. When we measure the testosterone, we measure the total testosterone, which is the whole amount of the bound and the free one. But sometimes there are certain conditions that will affect the albumin or the sex hormone binding globulin, so that will make it bigger or smaller. So the total testosterone might look bigger, but it's actually the free testosterone is the same. The same story happens if they have a smaller testosterone there. The smaller sex hormone binding globulin will cause the total testosterone to be smaller, but the free one is the same. And the common condition that you probably need to be aware of, that the total testosterone might not be accurate in people with moderate obesity. So it might be a good idea. Their total testosterone might be 200, but their free testosterone might be normal. And if that's the case, then they don't have hypogonadism typically. Nephrotic syndrome will cause that as well. Hypothyroidism, the use of any steroids, typically other than estrogen, it will cause problems with reducing the sex hormone binding globulin. Things that will make the sex hormone binding globulin bigger is aging, and it's very common to find people with older people with normal total testosterone, but the free testosterone is the one which is low. And it's very important to understand that and order the right test when that happens, when you suspect a problem with the sex hormone binding globulin. So causes of hypogonadism, and the question for that is, what do you think a cause for low testosterone with low LH and low FSH, and they have trouble with smelling? What's the syndrome for that? Is it Prader-Willi, Klinefelter, Coleman, or Sandra syndrome? All right, so actually the right answer is Coleman syndrome. So this is a genetic disease in which the gonadotropin-releasing hormone neurons are not developed properly, and they're associated with olfactory bulb problems. So they have problems with hypogonadotropic hypogonadism with absence of smell. Klinefelter, on the other hand, is the one that there is an extra X chromosome, so they will have hypergonadotropic hypogonadism. Their testes will not be able to produce enough testosterone there. So when I try to find out the causes for hypogonadism or low testosterone, I usually try to go back to that physiology, to that cartoon, and try to figure out where the problem is, because that will help us in actually diagnosing it and knowing what the treatment is for it. So if the problem is in the hypothalamus or the anterior pituitary gland, we call it hypogonadotropic hypogonadism. So there will be low testosterone with low LH and low FSH. And a common causes for that is pituitary surgeries, Coleman syndrome, if there's an excessive prolactin production or prolactinomas, and even pituitary tumors will cause that hypogonadotropic hypogonadism. On the other hand, if the problem is actually in the testes, which is either the testes are removed surgically or they had infection in the past, common is like mumps or orchitis when they're adolescents, or if there's a genetic problem, chromosomal problem like Klinefelter, then the problem is we call it hypergonadotropic hypogonadism, in which the FSH and LH will be elevated, but the testosterone will be low. And there's rarely problems with the testosterone receptor, in which there's testosterone resistance or some sort of aromatase inhibitor. That's rare causes for that. So how can we diagnose the low testosterone? And really the diagnosis should come into having the signs and symptoms of hypogonadism, which we'll be talking about, and then have the confirmatory lab that will confirm that. And usually early morning testosterone, total testosterone will be the choice for that. The problem with the testosterone symptoms, they're very, very non-specific, and you can really choose whatever symptom and say it can be from hypogonadism. And that's the problem, because sometimes it's very hard to know this is related to low testosterone or not. The more specific ones, if they have reduced sexual desire, problems with erections, gynecomastia, loss of body hair, that's very, very specific. It will be really obvious if that's what the cause. Osteoporosis in men is that's one of the very common causes of osteoporosis in men. So definitely if you have a man with a low bone density, that's something to look at. And hot flashes can happen actually with low testosterone in some cases. The less specific symptoms, which I like, these are the most of the time we'll get these symptoms. So people coming saying that they used to bench 300 pounds and now they're benching 275. Probably their testosterone is low. Fatigue is a very common symptom. Poor concentration, but that can be anything. It's very hard to know if this really related to low testosterone or not, but that's suggestive. And the problem with, again, with the media, if you go online and try to Google low testosterone, you'll have like a questionnaire. All the questions are very non-specific. Do you feel tired? Of course I'm feeling tired. Are you gaining weight? Yes, of course I'm gaining weight. What else? So they give you all non-specific symptoms, and they was like, well, talk to your doctor about testosterone, because this is probably what's happening. So in general, if you have symptoms and signs that you're concerned about low testosterone, then the first thing you need to do is early morning total testosterone and fasting. You do the free testosterone with that if you have a suspicion that there's a problem with the sex hormone binding globulin. So if they're a little bit morbidly obese, I'll add the free testosterone with that. If the testosterone is really normal, and that's where the really fine line is, or the gray zone is, what's normal here. And I think if it's higher than 300, definitely there's no low testosterone problem. If it's lower than 300, you can really raise the question. I think in our lab it goes at 240, I think, 247 nanogram per deciliter is our normal. But I think if it's low, if it's in the 200, it's warranted to repeat it again and possibly do a free testosterone with it. So if it's abnormal lower than 300, then you go to the next step and repeat it again. Do it in the morning, fasting, and add probably FSH and LH, and do a free testosterone with it to know what's the cause of it and to confirm that this is the problem. If it's normal and repeat, then they don't have low testosterone problem. If it was abnormal, then you can define it. Is it because of a primary problem with the testes not working properly, in which their LH and FSH are elevated and the testosterone is low? And usually you either do karyotyping and talk about treatment, or is it because of the pituitary gland not really producing enough signals there to cause the testosterone to be low? So you might need to check the prolactin to get sure there's no prolactinoma, check the iron levels to get there's no hemochromatosis, and consider doing an MRI. The question is when to do an MRI on a person with low testosterone with really borderline LH and FSH, and really there's no really strong guidelines on that. I usually, if it's lower than 200, I typically do an MRI to get sure that there's no really pituitary structural pathology. So how do we treat it? So once we know what it's common, we know how to diagnose it, we know what the cause is for that, then we need probably to talk about the treatment for that. So this is one of my patients. Well, let's pretend that's one of the patients. He came asking for low testosterone. I need my testosterone to be checked. I'm feeling tired. I'm feeling having low sex drive, and check his testosterone, and it's 100, and his LH is undetectable. And an exam is a remarkable exam, really, other than he's a little bit muscular than normal. So what would you do with him? I guess the questions were, do you send him for an MRI because his LH is low and he has low testosterone? Or would you start him with testosterone replacement? Or would you check his liver enzymes and see what's going on there? And usually I would do that because that's probably exogenous testosterone production. And you can't imagine how frequent we see that. Young men typically use, for some reason, they use exogenous testosterone for athletic reasons, and they come, and once you see somebody who's very muscular, that should be the first question: is he using any supplementation there? And then once they stop the supplementation, the body will go into a short period of hypogonadism, and the testosterone will be undetectable. But it's not because they're really not producing endogenously, it's just because the body is recovering from that insult that happened. So usually when we treat hypogonadism, usually we'll look at different aspects of that, and depending on the cause, usually the treatment can be focused according to the cause. So if the problem is in the pituitary gland or the hypothalamus, then there's actually other options than testosterone. If the problem is in the testes, testosterone is the only thing that we can actually do with that. But if it's in the hypothalamus and pituitary, So you have to treat the underlying cause. If there's a prolactinoma, you need to treat the prolactinoma. If it's a big pituitary tumor, that needs to be treated. If it's a hemochromatosis, that needs to be treated. If it's common, we can sometimes use HCG and FSH supplementation to induce spermatogenesis and to help with the testosterone production. There's limited study about using Clomid and clomiphene in hypogonadotropic hypogonadism to boost the endogenous production of testosterone in the absence of any pituitary structural pathology as well. So there's more options than only testosterone if it's really the pituitary gland. But testosterone can be used as well, and it's also most of the people will be on testosterone for that. So we have different testosterone formulation. There's the transdermal ones, which are the more physiological ones. The androgel and the testosterone is the oldest ones, and they come in a gel that comes in a pump, and you apply it to your hand, and typically rub it to the shoulder area and let it dry, and you wash your hands very well after you do it. What happens with that is the chances of transmission gets higher because you're just putting it in your hand and trying to put it in your shoulder there. So 3 years ago, the FDA approved 2 new products, the Fortesta and Exeron, and both of them to reduce the cross-contamination from using the testosterone. So the Fortesta is the one on the right corner here, and the idea of using it, you put a small amount on one finger and rub that finger in the inner thigh there. So it doesn't, one finger is only contaminated there, so the risk of cross-contamination will be less. The other one is Exeron, the one that you actually apply underneath the arms. So you have an applicator, you apply the gel there, and you put it underneath the arms, so the cross-contamination is less. Androderm is the patch, and one of the oldest actually testosterone formulation as well. The problem with the androderm, people will get skin reaction frequently with it. Now there's injectable forms. These are the cheaper option. So testosterone cypionate is the most common one that we use. There's enanthate, and there's the new one, which is Avid. I haven't used that so far, but it's supposed to be given at 0 and then 4 weeks and then every 10 weeks after that. So it's a very, very long-acting testosterone formulation. The problem with it, there's a lot of safety concerns about oil embolus happening from giving these shots. So you have to watch the patient for an hour after you get the injection, that type of thing. So it's really not gaining a lot of publicity there on that. Testosterone pellets, another one that some areas they use that. What happens, they actually insert small pellets every 3 to 6 months. The problem with that, it's a procedure, so you have to get that done every 3 to 6 months. And I think you run out of space after a while. Buccal testosterone, you put it in your mouth. Problems with taste, it's not really, sometimes you swallow it, it doesn't get absorbed very well there. Lately, they approved actually, it's not in the market yet, but it's actually something new, which is the intranasal testosterone gel. You apply it to the nose, and hopefully it will be probably in the market soon. That might actually be an easier option than other ones. So what's the difference between shots and gels, or the patches, transdermal versus shots? Is it better to get patches? Is it better to get the gel? Is it better to get the testosterone shots? And I think this slide will represent what the problem with the shots. The shots will give you a big bolus of testosterone that the first 3 days you'll get a supraphysiological level, like in the 1,000, that will cause problems. That will cause you to have polycythemia, having prostate issues. That can be related to these peaks that happens after the testosterone injection. In comparison to the gel, they'll give you more steady, or the transdermal in general will give you more steady level. Now, one way that I've been doing is trying to get the testosterone shot on a smaller dose more frequently. So instead of getting this big peak, probably getting a smaller peak and give it more frequently, so it will get probably in the within the target range, which is 400, 700 nanogram per deciliter. That's my target there. And I've been having good success with that. So that's a cheap option. At the same time, it's more physiologic. It's still, there's a lot of troughs and peaks there. So transdermal is more physiologic, but it's more costly. And the cost is really prohibitive in most of the cases. It's more painless with the transdermal, painful with injectable, but it's once a week or once every 2 weeks. Transference is the big issue here, especially with young families, because you don't want to really transmit that testosterone to the kids. The convenience, probably the shots are more convenient because you don't do them as frequent as a gel. So the things that are contraindicated to be used or to prescribe testosterone for is definitely metastatic prostate cancer and breast cancer. Prostate nodules, high PSA probably needs to be looked at before you start the testosterone, because you don't want to aggravate something that will get worse with time. And if they have a lot of urinary tract obstructive symptoms, then that's another thing. And severe congestive heart failure because of the water retention that happens from testosterone replacement. Possible side effects. Polycythemia is the most common, and that's something that it probably needs to be monitored for. Acne, if it's really supraphysiological, can happen. You'll be checking the prostate frequently, so the chances that you'll be detecting something is more common when you prescribe testosterone. There's no really study showing there's a direct relation between the prostate cancer and the testosterone per se. It's just it will make you diagnose something that was not really planning to be diagnosed soon. Gynecomastia with supraphysiological levels, the testosterone will be converting to estrogen, so that will cause gynecomastia. Male pattern balding. I did not use testosterone, by the way, so if somebody's asking. Worsening BPH, growth of breast cancer, but these are really, really uncommon adverse effects. So you remember the first slides about the epidemiology and how the testosterone, lower testosterone, the people with lower endogenous testosterone have a higher cardiovascular mortality, higher cardiovascular problems. So the question comes into, do these people, when you supplement them with testosterone, do they do better? And that's an area of very, very big confusion there, and nobody really knows the right answer so far. But the question is it that it's like a chicken and egg thing? Is it that the low testosterone is the problem, or the cardiovascular problem is the problem? And are they really cause and result, or they are just coinciding to be together at the same time? So I think the whole media got excited after 2 studies published in the end of 2013 and early 2014, in which one was examining, both of them are retrospective studies, poorly designed, a lot of manipulation in the data there to try to make testosterone replacement causing cardiovascular problems. So one of them was a VA retrospective analysis of charts for people who are doing angiography, and seeing people with low testosterone and people with low testosterone and or replacement, if they have any difference in mortality after a year. And they found that actually when you look at the raw data, that the people who had low testosterone without replacement has 20% chances of mortality from cardiovascular causes after a year versus 10% for people who are taking testosterone. However, they did some modification, and they added 50 variables there, and they reversed all the results there. So now it's testosterone replacement is causing the cardiovascular problems. And I think it's really not really accurate. It's very, very poorly designed studies. We have plethora of data so far that's showing that testosterone replacement with the right diagnosis, the monitored treatment will lead to probably better outcomes for a cardiovascular standpoint. So weighing the entirety of the data, actually it showed actually improvement. If not, there's nothing really to be concerned from cardiovascular. But I think everybody agrees that there's more randomized control studies needs to be done. And I think there's one that's happening. I don't know when it will be end, but they're really doing on people aged 65 or older, putting them on testosterone when they have really low testosterone, and see if there's any really cardiovascular risk. So until then, I don't think that should be a contraindication. That should not be an issue here. And because of that, because of the data, very robust, everybody is like going crazy with the class action lawsuits and problems with that. So I think that's what made the media really go attention on that, is the amount of falsification or not. It's probably false advertisement in the way that they're representing the data. So typically we monitor low testosterone men when we place them on testosterone clinically to see how they're doing, to see any of the side effects that can happen from that. Hemoglobin should be checked probably every 3 to 6 months to get sure that they don't develop polycythemia. PSA and prostate exam at least once a year, and the testosterone levels should be monitored intervally. So what I want you to learn from today's talk is it's very common to have hypogonadism is very common. If you want to diagnose it, probably do a morning total testosterone, and then if that's abnormal, you repeat the second one with a free testosterone. And try to think about the causes of low testosterone, not just because he has low testosterone, we'll put him in replacement without underlying doing the underlying cause and knowing the underlying cause. And if you have the choice between transdermal versus injection, transdermal is better, but sometimes the cost is prohibitive. And so far, safety-wise, I think it's safe to use if the diagnosis is right. So as long as it's monitored and there's no really an absolute contraindication. All right. Any questions?
I was curious in the evaluation of your testosterone levels, is there any cross-reaction or difficulty with the adrenal hormones in evaluation?
It does not, no. There's nothing really to be concerned from, I mean, from testing. From testing standpoint, I don't think that being on, other than remembering that being on the steroid hormones in general will affect the sex hormone globulin, so you need to look at the free testosterone probably if you're taking other steroids.
Thanks, Rami. I always wonder, why some men, ED is probably a more common complaint than having low testosterone itself, maybe like 5 times more. If I have 5 men with ED, I do testosterone, only one of them will have a low versus other people. Especially in young people, they come is usually psychological and not with testosterone levels really. But is there any reason, is it just the axis? Is more hypo related to the gonadotrophins or?
So the relationship between the erectile dysfunction and low testosterone is that I think the sex drive will be a more accurate way of assessing actually the testosterone function, because the erection is more, it's more complicated than just testosterone. There's many things that involve nerves, blood vessels, and all of that. So my thoughts are, yeah, it's a good idea to check the testosterone, but not necessarily they will have low testosterone if they have ED and vice versa. So it can, most of the time, they coexist together, but not necessarily they have to be together all the time.
Some people bring up this, over-the-counter like growth hormones and gonadotrophins that they can see and they buy. I guess they ask, and I know there was a big scandal about that, I think, but there was nothing approved or anything, right, to use any similar products like the GnRH products or anything?
The GnRH, I don't think, actually if you give a GnRH, what happens if you get continuous GnRH, actually you will get suppressed the testosterone production there. So I don't know. There was one time the SCG was famous to be taken orally, which didn't make any sense physiologically for weight loss. And I think it was a big scam, and I don't think that there's any relationship with that. But no, it should not affect, if their testosterone is okay, they should not really, they should not be on testosterone.
What's the pathway for testosterone affecting the hemoglobin? Does it affect erythropoietin to increase the hemoglobin?
That's correct. Yeah, they increase the erythropoietin, and that will increase the...
And does estrogen do that too?
It does not, no.
Okay, thanks.
No, yeah. All right. Well, thank you for having me here.